everyone. So our group did our project on preventing human error through a quality improvement system. So to start, we're going to dive into some background about what medical error and quality improvement systems are. At only a year and a half old, Emily was diagnosed with a yolk sac tumor found in her abdomen. After months of rigorous chemotherapy, her last MRI showed that not only did the tumor disappear, but there wasn't even any residual scar tissue left, almost as if she had never had cancer. After her second birthday, she began her last chemotherapy session to be sure that there were no traces of cancer that could be left behind. However, after extreme pain, profuse vomiting, and brain damage, the doctors realized too late that she had been administered a fatal dose of more than 20 times the recommended amount of sodium chloride in her chemotherapy IV bag by the pharmacy technician. Emily was now brain dead and on life support. Her story is a reminder of how painful and momentous easily preventable medical error can be and how important it is that we reduce this occurrence. According to a 2016 Johns Hopkins study, there are more than 250,000 deaths per year due to medical error. Now surpassing deaths from respiratory diseases, preventable medical error is now the third leading cause of death in the U.S., falling only behind deaths from heart disease and cancer. This number is only projected to rise as care continues to be delivered more and more outside of the hospital. Massachusetts, a state that consistently receives high marks on patient safety, reports 62,000 medical errors in a year in that state alone. The cost of medical error is equally financial as it is human. Studies show that this preventable harm costs the U.S. $19.5 billion a year. Most medical error, however, isn't inherently due to bad doctors, but rather systemic problems like poorly coordinated care, fragmented insurance networks, the absence or underuse of safety nets, and other protocols. Knowing this, we can address these systemic issues with a quality improvement system. Quality improvement is defined as maintaining a high quality of healthcare by constantly measuring effectiveness of the organizations that provide it. The application of this concept, which has been proven successful in multiple industries, is the link healthcare desperately needs between better quality and increased patient safety. But for quality improvement to be efficient, it's important that all the aspects of this business are covered and ongoing evaluation is performed. This means utilizing total quality management, also known as Lean or Six Sigma, and PDSA cycles, both of which will be addressed later in the presentation. Now that we have a good understanding about what a quality improvement system is, we can discuss what makes it effective. Implementing an effective quality improvement system requires commitment and investment of resources. It requires continuous vigilance and monitoring, as well as upgrading or responding to ineffective processes. In order to enact change and improvement, the leadership and staff both need to be involved in the process and accept new ideas and concepts. Data allows for organizations to determine if the quality of care is improving, and if not, then to try and improve it with a different measure. This would ensure healthcare workers aren't wasting time, and it would garner greater trust for the QI system. Data must be measured, collected, and analyzed to ensure that the system is functioning properly, to determine how to improve a system, and to determine if the improvement efforts are effective. In healthcare, this is a difficult process as positive outcomes are dependent on multiple complicated factors. It is very difficult to design measures that directly indicate the impact of a certain quality improvement on the patient care outcome. Assessment requires significant investment from the organization as gathering information and analyzing it is costly. To determine where and how an organization is performing, clinical details found in patient charts are needed. The patient charts are often paper records, so data collection is a time-intensive process. In addition, once cracks in the system have been identified, research is needed to understand how to improve the system and which measures will be used to determine if evidence-based care was provided. It is important to ensure that the measure is reflecting the quality of care being provided to the patient. The process measured must be close in time to the desired outcome, or at least not too far removed, and must not have additional interventions that could affect the outcome. It's also important that the data measured does not lead to unintended consequences in patient care or incentivize the wrong tasks. PDSA, or Plan, Do, Study, and Act, is a method of rapid change that is like the scientific method. It requires a hypothesis in the plan stage, testing of the hypothesis in the do stage, analysis of the results in the study phase, and finally acting with further improvement or implementation of change. In PDSA, several cycles are performed in order to create an improvement, and while a team might not see the improvement after most cycles, it still teaches valuable information. The initial PDSA cycles could teach about problems, the next set of cycles could be about the interventions to solve those problems, and the final set of cycles could be the implementation. This method requires establishing a baseline, but the same information may be gained during the initial cycles, and the QI team could save on time required to establish a baseline. Another efficient technique is following a nonlinear path between cycles, so if a step is going to take a long time in another committee, then the team should move on to the next step while waiting. PDSA cycles are fast but have a high failure rate, so it requires persistence and asking the right questions to see the benefits. Lean and Six Sigma are QI processes that have been recently adapted for healthcare. Lean emphasizes taking the correct action, and Six Sigma prioritizes taking the action correctly. In conjunction with PDSA, Lean and Six Sigma can be utilized to improve patient safety. These processes work to reduce redundancies and waste in patient care. However, they are relatively new in healthcare, so organizations need to be cautious when applying these concepts for process improvement. This is because the link between Lean, Six Sigma, and patient outcome improvement is weak. These processes also require training department managers and hiring consultants to properly implement them. Despite these negatives, organizations continue to apply these QI processes because they do improve performance. An organization can save on consultant costs and hiring an expert in Six Sigma or Lean to be part of the QI team. A successful example of how these methods are utilized is the story of a community hospital in Dover, New Hampshire. Wentworth Douglas Hospital is a 178-bed Mass General community hospital with a CEO who had a vision for implementing an operations excellence program. The vision started with hiring a master black belt, Six Sigma, as the chief performance officer, who then built a team of black belts to develop a training program to certify additional black belts, green belts, and product managers throughout the hospital. His vision became an investment into a hospital-wide approach to utilize the tools of Lean and Six Sigma to implement change. Leadership must encourage and create opportunities for all workers to contribute to the work process because a healthcare environment with empowered workers can greatly improve care. Frontline workers may be engaged with the QI process through the implementation of the incident learning system. ILS allows employees to report safety events and near misses for the analysis, and it creates an opportunity for improvement throughout the entire department. It's important to analyze near misses and non-harming safety events to prevent negative outcomes in the future. The team analyzing the ILS report must consist of personnel from frontline and supervisory roles to create a meaningful policy improvement that is palatable for everyone. The challenge with this system is the high number of safety events reported requires prioritizing near misses and less common incidences. Moving on, we'll now discuss some barriers to quality improvement systems. The team looked at 4 barriers to quality assurance systems. The course material and research took an in-depth look at why medical providers face barriers to quality improvement given all the quality improvement tools such as root cause analysis, Six Sigma, and lean processes. The 4 barriers which we will explore are cultural barriers, technological barriers, lack of accountability, and communication barriers. It is a common phrase in any organization to hear, "This is the way we've always done it." Healthcare is not an exception. People are often afraid of change. Stagnation and routine can be the enemy of change. Often, new quality improvement measures require time and resources. It is necessary that leadership leads by example by demonstrating the importance of implementing new quality improvement measures. The leaders of an organization must create an environment to foster change by committing time and resources to the development of quality improvement measures. Additionally, the appropriate staff members should also be on the team. The staff should be given the space and time to implement the quality improvement measure. Further, it is imperative that there must not be an expectation that the improvement will yield immediate results. It is imperative that the Plan, Do, Study Act process be used in order to ensure that the quality improvement is continuously implemented and revised as necessary to ensure that the process is working. Most members of the medical profession understand that the electronic health records will lead to improvements in healthcare. There are many barriers and concerns regarding the implementation and maintenance of EHR. There are many articles regarding physician burnout. Physicians struggle between prioritizing patient care and updating the EHR. It is imperative that providers maintain the EHR programs and be able to maintain technology as it evolves. The maintenance and training on EHR is very costly. It takes both time and resources to learn and update EHR. The larger concern is that for many providers, EHR is limiting and the efficiency between the lack of interoperability of the EHR systems. As such, patients' EHR information is limited to the provider groups. It's necessary that the EHR becomes nationalized in order for it to be effective and provide comprehensive and continual care to patients as they travel and receive care from multiple providers. Disclosure is key in order to have effective and meaningful process improvement. If providers are not comfortable disclosing medical errors, we discover that process improvement measures are not as effective because there is not a full overview of the issue that needs to be resolved. The chart demonstrates the pros and cons of disclosure versus non-disclosure. Disclosure can lead to reduced litigation costs, the ability to heal the second victim, which is the provider, regain trust and integrity, and also provides the opportunity to have valuable quality improvement process development. Non-disclosure, however, may increase litigation costs and may also create patient distrust. It's important to discuss the need to provide space for the special victim, which is the physician that is involved in the medical error, and the importance of providing a supportive environment for the provider to disclose their errors to the patient and to management. The disclosure of error allows for an opportunity to repair the patient relationship and effective quality improvement. Disclosure also allows for open communication and accountability, both of which are vital to quality improvement. In addition to creating a quality improvement program and addressing the barriers that exist for developing a successful program, sustainability of a quality improvement system is essential for quality improvement success. The National Health Service in the United Kingdom identified that 33% of quality improvement efforts are not sustained after 1 year post-implementation. According to Bernstein et al. 2016, sustainability planning efforts should begin at the initiation phase of a project. Factors to consider include financial resources, IT resources, and the flexibility of workflow processes. Once a project has been implemented, determining readiness for sustained improvement is the next step. This is accomplished by completing PDSA cycles and establishing that sustained change has occurred. An example of sustainability measures including providing visual posters such as this one, with progress data as reminders to the staff, which will help encourage follow-through of a project. Posters also serve as a reminder to staff of data that's continuously being monitored and as a visual for patients and their families to see the commitment of a hospital for a culture of safety. The Joint Commission emphasizes a critical part of creating a culture of safety is the need for leaders to be committed to prioritizing and making patient safety visible through everyday actions. In addition, they identify effective leaders as those who see safety issues as problems with systems and not employees. One area developing a true culture of safety is mimicking the aviation industry's implementation of a just culture model within the healthcare organizations. This culture emphasizes the need for reporting safety-related information, but with clear lines being drawn between human error and at-risk or reckless behaviors such as falsifying records or performing duties while intoxicated. A just culture holds organizations accountable for the systems they design, as well as responding to staff behaviors in a fair and just manner. With safety being a core value of any accountable care organization, the Just Culture model is focused on improving safety and reliability through accountability and process design. In 2018, Press Ganey cited a Strategic Insights report that found quality improvements will only thrive in an organizational culture that aligns purpose, people, and processes. For example, at Wentworth Douglas Hospital, the executive leadership team supported and implemented a daily safety huddle to report near misses and occurrences. Creating a sustainable model for quality improvement systems is crucial for success in any healthcare organization. Executive leadership support is key, as is their ongoing efforts with engaging frontline staff, which includes occasional rounding on the floors to support a culture of safety. Empowering staff and practicing transformational leadership also improves patient safety because leadership support allows for the employment engagement and development, along with the retention of more experienced staff. In addition, implementation of a just culture model encourages staff to focus on system errors and not human error, as the healthcare staff should not be expected to conduct all practices without flaws. The healthcare industry still has a lot of work to catch up to with other industries, but efforts are being recognized and supported to move in the direction of a true culture of safety. And finally, we'd like to take a few moments to summarize our findings from the project. In conclusion, quality improvement measures are the greatest resource to reduce adverse events and near misses. Utilizing improvement methods such as PDSA cycles will allow for effective goal setting, data collection, analysis, and implementation of change. Without structured processes and methods, implementing change can prove to be difficult and not motivate others to adapt improvement efforts. However, if leadership supports a culture of safety and allows employees to come forward about errors in a safe environment, necessary changes can occur to improve the healthcare system and protect patients by providing patient centered care.